Hello, everybody. Dr. Ryan here. I'm a board certified specialist physician. Thank you so much for joining me in this hour. I think it's our seventh didactic approach in internal medicine. I hope you and your family are well. If you haven't yet subscribed to my channel, I would love to have your friendship on the channel. So you're invited to like, share, and subscribe. Thank you so much. Jaundice is a very common clinical presentation to internal medicine. And there are many ways to think about jaundice, but I particularly like this approach, right? Jaundice can be either prehepatic, meaning usually hemolysis, right? It can be intrahepatic in the liver or posthepatic after or outside the liver. So prehepatic largely hemolysis, right? So, or it could be due to decreased uptake, decreased conjugation, Gilbert syndrome, certain drugs as well. Now, how do you know somebody is hemolyzing? For one thing, the hemoglobin will be low, the unconjugated bilirubin fraction will be up, the haptoglobin will be low. And if you think about haptoglobin, it's like mop that mops up all this extra hemoglobin floating around from the hemolysis. So haptoglobin goes down, your LDH, your lactate dehydrogenase goes up because that's liberated from the lyased red blood cell. If your bone marrow is intact, your reticulocyte production index will be high. If it's autoimmune hemolysis, Coombs will be positive. And a smear, if there's microangiopathic hemolytic anemia, will show you schistocytes or fragments, right? So that's hemolysis. Now, intrahepatic is the broadest category for causing jaundice. Uh, and look, we have cirrhosis, which is probably chronic liver disease. Some people use those terms synonymously, but cirrhosis classically is a histopathological diagnosis. It refers to fibrosis of liver parenchyma with areas of nodular regeneration interspersed between them. And often it gives rise to portal hypertension and numerous consequences, right? If the patient's minimally symptomatic, then that's another branch point. Or they could have the thousands clump, which refers to acute symptomatic or massive increase in your transaminases. And the fourth is if the patient is pregnant. Okay, so let's look at this in more detail. Cirrhosis, we covered the causes before A, B, C, D, E, F. So A stands for alpha 1 antitrypsin deficiency or autoimmune hepatitis. B is for hepatitis B or Buchiari. C is for hepatitis C, also called copper overload, speaking to Wilson's, or cardiac cirrhosis. D is in the way of drugs, and more drugs, right? You know those deals right there, guys. A lot of drugs can cause cirrhosis. Methotrexate, okay, as an example. E is for blaming on the ethanol, so ethanol, alcohol, right? And F is fatty liver. I can also speak to F for iron, Fe, and that's hemochromatosis, right? So those are the causes of cirrhosis. But by and large, where we are in sub-Saharan Africa, alcohol and hepatitis B are the leading causes, right? So also consider congenital biliary atresia, Buchiari we spoke about. So what you're going to do, even if the patients are minimally symptomatic or have cirrhosis, obtain imaging in the way of ultrasound scan of the abdomen, look at the characteristics of the liver, the echo texture, look at the size, is there hepatomegaly or is it a small truncal liver cirrhosis, look at the dimensions of the portal vein, and search for other causes of liver injury if there's viral hepatitis to hepatitis. Serology, right? Hepatitis B surface antigen, hepatitis B core immunoglobulin, is it IgM, IgG? Look at hepatitis B E antigen, look at hepatitis B surface antibody and E antibody, etc. And of course, look at your hepatitis C immunoglobulin as well. Obviously, take a history if the patient is using alcohol, because that's one of the main proponents for cirrhosis. Drug history is important. If the patient is concomitant diabetic, has cardiovascular risk factors, be on the lookout for non-alcoholic steatohepatitis, non-alcoholic fatty liver disease. By and large, that's a diagnosis of exclusion, right? Autoimmune etiologies, if the patient has other concomitant autoimmune conditions, right? And then the antibodies, if you strongly suspected, especially young females, childbearing age, anti-nuclear factor, anti-smooth muscle antibody, with or without anti-liver kidney microsomal antibodies, right? The congestion, obviously, cardiac cirrhosis, do your echocardiogram, establish your left ventricular filling pressure, establish your ejection fraction, and so forth. Hemochromatosis, the test you want to do is your iron studies. And what we're looking at is a transferrin SAS percent above 45%, together with an elevated ferritin. Wilson's disease, you want to do your serum ceruloplasmin. Classically, it's low, and you want to do a 24-hour urine copper. Of course, to do a stent lamp examination of the eyes, you're going to find beautiful caves of rings. Alpha-1 antitrypsin deficiency, a young patient with no smoking history, with low predominant emphysema, together with cirrhosis, right? Then there's a couple of things which don't cause cirrhosis, cause jaundice because of massive elevations in the transaminases. If we're talking about so-called shock liver, if your patient had an episode of hypotension for whatever cause, there could have been diminished blood flow to the liver, which has now caused the liver to become ischemic. That can increase your transaminases, and as can acute viral hepatitis, hepatitis A, B, E, cytomegalovirus, Epstein-Barr, herpes simplex, dengue. Toxins, especially paracetamol overdose, and that got to give Pavlex, which is N-acetylcysteine, in such circumstances acutely, and of course, acute Budd-Chiari can also do it. If the patient is pregnant, you must obtain the diagnosis of intrahepatic cholestasis of pregnancy or acute fatty liver pregnancy HELP syndrome, which is hemolysis, and elevated liver enzymes, low platelets. But don't forget, hepatitis E often flares in pregnancy as well. Post-hepatic causes, we split it into whether it's painful or painless. If it's painful, next part of call is ultrasound scan or CT and looking for dilated ducts, giving you evidence of obstruction. Then you're thinking about cholangitis, Charcot's pentad, fever, jaundice, right, upper quadrant pain. If you add hypotension and altered mentation, that's Raynaud's pentad, which is septicemia secondary to cholangitis, right? Choledocholithiasis is a fancy way of saying, look, there's gallstones in the bile duct. Okay, and hepatic abscess, liver abscess, right? If it's painless, to a CT abdomen, because now you're probably thinking, is this a malignancy of some sort? Especially pili mass, example, pancreatic cancer. You're thinking about hepatic abscess, you're thinking about malignant infiltration. Consider MRCP if you got no duct dilation, okay, and then from the ultrasound or from the CT, you got no duct dilation, do an MRCP. If you got non-dilated ducts, probably what's driving the cholestasis is drugs, like augmentin, for instance, PBC, which is primary biliary cholangitis, and anti-mitochondrial antibody. If the ducts are dilated, you're thinking about primary sclerosing cholangitis, which has an association with ulcerative colitis, don't forget. Malignancy, liver flukes, I'm not fluking you there, liver flukes, like trematodes, like trypanosomiasis, for instance, right? HIV cholangiopathy, right? Sometimes you get isolated conjugated hyperbilirubinemia. Then you consider Joubin-Johnson and Roche's syndrome. Okay. Remember that alk-phos and gamma GT are also your ductal enzymes, which would go up with post-hepatic causes of jaundice as well. So this is another fun mid-comic. Thank you to Mr. Jorge Muniz and company. So pre-hepatic, we said hemolysis, right? Transfusion reaction, sickle cell anemia, thalassemia, autoimmune, you know the deals, guys. Hepatic means there's something intrinsic to the liver that's driving it. So we're talking about cirrhosis, and we went through A, B, C, D, E, F, hepatitis, cancer, congenital disorders, ethanol, drugs. And post-hepatic is anything outside or after the level of the liver, the stones, worms, and tumor, surgical causes of jaundice. Okay, my friends, the book of Isaiah, chapter 66, verse 2 says, I am pleased with those who are humble and repentant, who fear me and obey me. Jesus said, come to me, you who are weary and heavy laden. Take my yoke upon you and learn from me, for I am gentle and humble in heart, and you will find rest for your souls. If you're tired of living a life of sin, if you're tired of being overcome by iniquity and the burden of sin, if you're tired of condemnation, come to Jesus and learn humility and gentleness from him. God bless and I'll see you soon. My references